So external beam radiation therapy, basically radiation is delivered in two ways. One is externally, second is internally. Majority, 90% of cases are treated with external beam radiation therapy. And in some cases, internal radiation or brachytherapy is also utilized. For example, in cancers of cervix or uterus or of oral cavity. In some centers, even breast brachytherapy is done. But that constitutes around 10% of the treatment cases. Next, please. This external beam radiation therapy can be delivered by machinery which is known as linear accelerators. These linear accelerators are the machines which deliver high energy X-rays, which are focused and highly conformal targets are treated inside the body with the help of these machines. Now, there are various techniques which are utilized while treating the patients. Uh, they are known by various nomenclatures like 3D CRT, IMRT, IGRT, rapid arc. Then we have got highly focused stereotactic radiotherapy and even particle beam therapy like proton and neutron treatments occur at designated centers. Next, please. So the radiation therapy delivery is basically painless because it is delivered by X-rays, and it is usually scheduled 5 days a week for 1 to 7 weeks, depending upon the amount of dose that needs to be delivered. The effects of radiation therapy are cumulative, with most significant side effects occurring near the end of the treatment course. However, these side effects are temporary and usually resolve over the course of a few weeks. Now, treatment durations can range from 1 to 5 days for stereotactic or palliative treatments, or 3 to 7 weeks, which are usually utilized for conventional treatment in various sites across the body, including brain, head and neck, breast, lung, abdominal structures, or genitourinary structures. Next, please. Stereotactic radiosurgery is one very specialized form of radiation therapy, which uses a high dose per fraction of radiation in a very focused and precise way, and gives us a high probability of local control, more than 90%, because of the doses that we use, and it can be done safely for well-defined small medium sized targets using our most advanced treatment technologies to deliver this very potent dose safely. Specialized equipment is utilized at Ruby Hall. The name of that machine is known as CyberKnife, which and on which we perform our stereotactic radiosurgery treatments for all our patients. Next, please. So, when stereotactic treatments are done for targets in brain, it is known as either SRS or SRT. So, if it is done in a single fraction, so it's known as stereotactic radiosurgery. Like doing a surgery, it is finished in 1 day, hence it is called stereotactic radiosurgery. However, sometimes the targets are very close to critical structures in the brain. So the treatment has to be divided into 2 to 5 fractions. And then it is known as stereotactic radiotherapy. The treatment is basically frameless and non-invasive. No pain occurs to the patient when the treatment is going on. The indications for these treatments can be for benign tumors like acoustic schwannomas, meningiomas, arteriovenous malformations, even trigeminal neuralgias, and other functional indications are there. Malignant tumors of brain like brain metastasis and gliomas, that means the brain tumors, are also treated with SRS or SRT. Next, please. Now, when this stereotactic treatment is done in other parts of the body, it is known as SBRT. It can also be done in 1 to 5 sittings, and similar machinery is utilized even if we are doing SRS or SBRT. CyberKnife is utilized for this treatment. The indications can be for metastatic lesions like metastasis present in the nodes or bone or liver or brain metastasis or lung lesions. And even SBRT treatments are now being utilized for small primary tumors present in lung or prostate. So the treatments which used to take around 6 to 7 weeks to finish can now be finished in 5 sittings with the help of utilizing SBRT techniques, and we are getting good cure rates also. Next, please. Brachytherapy, as I had explained, is the internal usage of radiation, which is utilized in certain sites. Next, please. So this technique is around more than 100 years old, even older than external beam radiotherapy, because when the radioactive sources were first discovered, they were utilized to treat cancers in skin or on the outside surface of the body, and then the tumors were placed near the tumor. So it allows increased dose escalation by sparing normal tissues. Next, please. Intracavitary brachytherapy is routinely utilized at our center for treating the cancers of uh, female genitalia, basically. So, cancers of cervix and uterus or even vagina can be treated utilizing this. However, interstitial brachytherapy, this is intracavitary brachytherapy, which is happening in a body cavity. But if brachytherapy is done by implanting needles in the cancer directly, this is known as interstitial brachytherapy, and it can again be utilized for genital malignancies, and even at many other sites it is being utilized by many of the centers, but it requires high technical skill, and hence it is utilized only at specialized places. So some examples of these cancers are cancers of oral cavity or tongue or lip or even breast. So these cases are in which tumor, either the needles are placed inside the tumor or inside the post-op cavity, and then the treatment is given within 1 to 5 days. Next, please. Yeah. So this is an example of interstitial brachytherapy happening in the cancer of buccal mucosa, topmost picture. Then on the left-hand side, it's a sarcoma. And this side, it is showing how the needles are placed through the skin and into the tumor directly. Next, please. So the current principles of delivery of radiation therapy as has been since day one, but because we have achieved a lot of technical innovations and modifications, the principle is to maximize tumor control and reduce side effects by controlling doses to organ at risks, which are in proximity to the tumor. We intend to give highly conformational planning with sophisticated algorithms now, utilization of AI, robotic architecture. A lot of innovations have come up. Reduction of treatment days is one of the main goals with the adoption of hypofractionation. In the beginning, I can put even 15 years back, a lot of treatments were given because for 6 to 7 weeks, or even in cases of CA prostate, they took around 8 weeks. The patient needs to come to the hospital 5 days a week for 8 weeks, becomes very tiring. So now, because we have achieved a lot of conformality, our planning has become better, our delivery has become even sophisticated. So now we are able to push in higher amount of doses in a day, where we are able to protect the normal organs also very well, and hence the number of days of treatment has been reduced. SRS, SRT, and SBRT is one of the prime examples of how this treatment is utilized. Also, as radiation therapy has become safer and higher doses can be pushed with minimal side effects, organ preservation has become a very consistent approach where we try not to remove the tumor but treat it directly with the radiation so that a critical organ can be preserved and the patient's quality of life is maintained. Some examples are cancers of larynx, in which the earlier principle was to remove the entire larynx, and the patient would have been rendered speechless for the entire life. But now, when we give radiation to the larynx in a curative intent, the cancers, when they are cured, the larynx is preserved and the patient is also free of cancer. A similar approach is utilized in cancers of prostate or urinary bladder also, where organ is not removed because these surgeries are, although curative, but can lead to certain side effects that can be troublesome to the patient post the surgery. So by giving radiation, we are able to preserve that or those organs to improve the quality of life of the patient. And also, as more and more innovations are happening in medical oncology part also, so now the patients are living more, and hence we are seeing more and more cancer recurrences. So when these recurrences happen, there is a chance to re-irradiate those sites, and we are now treating even 2 times or third time also same site, and re-irradiation is increasing with better tumor control and longer lifespan of patients. Also, Now there is something known as oligometastatic disease, in which suppose a cancer in a breast or lung or any other cancer comes up with one or two metastases in the body, for example, in the brain or bone, and these are actually treatable. So now what we are doing is not labeling these patients as metastatic, but labeling them as oligometastatic, and we proceed with treatment with curative intent. So these patients are not left for palliative treatment, but we are now going ahead with increased utilization of radiation for these places, for these sites, and we are getting more and more cures. Next, please. So the facilities available at Ruby Hall, we have two high-end linear accelerators, world-class TrueBeam STX and Halcyon machine. So these are utilized for all the routine conventional treatments for all our patients. Next, please. Now, these photos or CT images are some examples of how we usually plan our treatment for a better visualization on your end. So, for example, this is a brain tumor patient who has come to us post-op. The tumor is on the right side of the brain, and you can see a post-op cavity and on the CT and MRI. Both CT and MRI images are utilized for the planning purposes. Next, please. And this colored area, the reddish blue green area, is the dose profile. That means you can see that the post-op cavity needs to be treated with high doses of radiation so that the tumor does not come back. And the planning is done in such a way that you can see that the high dose region is the actual post-op bed, whereas the remaining normal brain does not receive or receives minimal doses of radiation. Next, please. Similarly, this is a case of CA lower lip, which was which presented to us post-op, and as you can see, it requires the treatment of lip and bilateral neck regions. So the treatment volumes you can see. Next, please. And this is the dose profile, because you can see more red on the right side because the tumor was on the right lip and with a node positive in the 1B region. So hence that region is treated with high dose, and the remaining yellowish dose, as you can see, is basically low dose region that is also treated because the cancer can reoccur in any of the sites, as the tumor was in the midline. So we need to treat the entire region, and you can very well appreciate the high dose regions, the low dose regions, and no dose regions on these images. Next, please. Now, an effect of radiation is that the skin gets pigmented. The skin becomes dark. So this is the same lady whose plan was shown to you. So basically, you can see that the lower lip region, the chin region, and the neck region has been treated because of the skin pigmentation that has happened. This pigmentation goes off in around 3 to 4 weeks. And as you can see, the upper lip and the other parts of the face are untouched because they did not receive any radiation. Next, please. This is an example of a cancer of breast of the right side. The patient has presented to us post total mastectomy, breast conservation surgery. And next, the entire breast is getting treated. As you can see, just behind that right breast is the lung and the heart. And because of high conformability, the doses achieved are only in the breast region and they don't go to the lung or the heart. Next, please. The case of CA lung, which is very close to mediastinum, and as you can see the CT and the PET images side by side, you can very well appreciate the reddish portion that is the entire tumor. Next, please. So this is how the planning has been done, the high dose region to the tumor with good preservation of both lungs and heart also. Next, please. Another case of CA prostate, in which this is basically the prostate is being treated, and you can see the high dose region in the prostate while simultaneously preserving the bladder and the rectum. Otherwise, there will be a lot of side effects if older techniques were utilized. Next, please. This is an example of pituitary adenoma. which presented to us post-operative. The intent of neurosurgery in such cases, a big pituitary adenoma, the intent is to debulk the tumor as safely as possible. And once that is done, this tumor needs to be treated because brain is a closed structure, and any growth of the tumor further can lead to a lot of neurological issues. So this radiation, which is given to this pituitary adenoma, has to navigate a lot of normal structures, including the normal brain, both eyes. Then we have got brainstem, optic chiasm. Everything is very closely placed in the brain parenchyma. So the high dose region has been tailored in such a way that all these organs, normal organs, are protected so that it are delivered minimal dose of radiation, and the highest possible dose that can be delivered safely to that pituitary tumor is done. This treatment is usually done in 5 settings. Next, please. So basically, this was in short a compilation of the principles of radiotherapy, the intent, how radiation therapy has progressed over the years, what treatment modalities we are utilizing, and how well we are able to now treat with the indications, so that you get a fair idea that radiation oncology, what radiation oncologists usually do. Because many a times patients come to us with this nomenclature that they want to do radiology, but radiology is basically diagnostic imaging. Then they say light dena hai, shake dena hai. So all these were old nomenclatures when which were utilized in the era of cobalt treatment. That was how it was basically made for understanding for common people. But now, since we do understand that things have moved on, it is we prefer that people call us as radiation oncologists, and they understand that what radiation therapy is. So I conclude my talk with this.
Thank you so much, Dr. Neeraj. I guess it's been a very enlightening talk. I guess we learned a lot about radiation oncology, which was very great to us till now. We learned about ionizing and non-ionizing radiations. I loved the concept of the Army, Navy, and the Air Force, and the entire radiation therapy team, which takes care of right from radiation oncologists being at the top of the hierarchy, and the physicist as well as the radiation therapist, along with the radiation oncology nurse who forms the entire team which handles the entire radiation therapy given to a patient, about how the precision of these radiation treatments have increased manyfold, such that the normal surrounding tissues are not damaged or altered by the radiation. So we as physiotherapists come much later in the rehab of a cancer patient, and usually we deal with a lot of morbidities which are left behind, or some impairments which are left behind after the treatment is over. So we do see a lot of patients with either lung cancers for their chest physiotherapy later on, or a breast cancer patient who has been treated, even head, face, neck tumors, brain tumors also in case they are left with neurological deficits. So my question to you, I mean, the whole thing has been really, really informative, and I've come to know a lot of terms which were basically just, the short form was something that I knew, but I didn't never knew what went into it. So we have been getting more clarity about all these terminologies like SRS, SRT, SBRT, and the host of radiation treatments that you mentioned. I just have one question to you, that in case post following the radiation therapy, we encounter a lot of fibrosis of the tissues. I mean, there is a darkening of the skin, which you just mentioned, but we do experience also a lot of fibrosis which takes place. So from that point of view, I mean, how soon can we usually treat these patients for their mobility? Any idea?
So basically, the intent is to prevent fibrosis and try to have the patient as mobile or the
Mm,
joints as mobile as possible from day one.
Hmm.
So what my approach is to involve the physiotherapist at the very onset. For example, a case presents with CO of oral cavity who has been operated for either buccal mucosa or tongue, has a flap in situ, the joints, the temporomandibular joints were frozen because of extensive tobacco usage. So these patients have
Hmm.
very narrow mouth opening.
Hmm.
So the intent is to involve the physiotherapy from day one with the usage of head and neck exercises, the muscular strengthening, the mouth opening exercises, the speech and the swallowing exercises. All these are required from day one, because if I wait till radiation to finish off, then these things get permanent.
Exactly.
So the best way is to motivate the patient from day one. It might happen during the course of the treatment that these, because of the mucositis, it becomes difficult for the patient to continue with the exercises at the later or at the fag end of the treatment. But then that is acceptable if the patient has been doing this, because now he is well informed as to how what he needs to do. The patient has to be motivated a lot, and
Hmm.
that is something which I do routinely in my practice. But then still, there are shortcomings that happen because of the previous malformations that has happened because of
Hmm.
the nature of tobacco chewing, which is causing some mucosal fibrosis and other things. So these things have to be started at the onset only. It's not like
Hmm.
कि मेरा complete हुआ है और फिर मैं 1 महीने के बाद अब जब when the things have set in, then I send in for physiotherapy does not make sense, because it makes uh, life difficult for all three of us, me, the patient, and you. So the approach is to initiate it since the day one of
That's
radiation.
it.
For all the cancer treatments that happen, wherever physiotherapy is required, should be instituted, and there is no need to delay anything.
Thank you so much. So, from the entire team of Physio TV, I would also like to kind of thank Dr. Parag Sancheti sir, who's our chairperson, Manisha Sangvi ma'am, who's our executive chairperson of the Sancheti Healthcare Academy, and the entire team, along with the IT support which is provided from Physio TV. I would like to deeply even thank our speaker today, Dr. Neeraj Dingra. I'm sure this talk is going to go a long way in us understanding how radiation oncology can further the treatment or help in the treatment of many cancers, right from the brain to other parts of the body. And it has given us a new dimension about how we can. So we know now that when the patient is being treated for cancer, what is the exact role of a radiation oncologist here? And of course, the cyber knife has added a really new dimension to the entire treatment, and we look forward to such interesting talks. And I'm sure we will invite Dr. Neeraj again sometime in the near future or in the distant future, whenever sir is available, for another talk on radiation oncology, if possible. But from now, let me just say a nice thank you from all of us. Thank you for taking out so much of your precious time for this talk. And thank you from the entire team of Physio TV. Thank you, sir.
Thank you so much. Have a good day.
Thank you. Yes, sir. So that's that, and we have finished with the recording. So thank you so much, and a lot of hiccups in the start, but I hope we just got it through, and I'm just hoping that the audio comes clear and perfect.
I also hope so.
Yeah, yeah, yeah.
That
Thank you
we are
so
going to
much.
like
I'll
recording.
also tell Suroshri that, thank her also. I mean, she has been instrumental in putting this talk across. And we look forward to kind of helping a lot of patients reach your way, if that's possible, at least among relatives and all that we know, to kind of come and consult you sometime in case there's a need.
Thank you. Thank you.
Thank you. Thank you so much.